Hello everyone, welcome back to our channel. I'm Dr. Ashmita. Today in this video, we shall continue the second part of acute viral hepatitis. In our previous video, I have discussed about the pathogenesis of acute viral hepatitis in detail, and it includes the entry and spread of virus. We have completed hepatocyte infection, the immune response mounted by the host, which includes innate and adaptive, hepatocellular damage, inflammation. Till here we have completed in our previous video. We shall continue from there, and because of this pathogenesis, what are the consequences, pathological consequences on morphology of the liver that we are going to cover now. So in this video, we'll study about the morphological changes which include both gross microscopy, pathophysiological consequences, regeneration versus failure, and the outcome, clinical complications, clinical features, the complications, and lab investigations. So let's begin. So the morphological changes that occur because of hepatitis are: firstly, there is hepatocyte degeneration. The hepatocyte degeneration can be in the form of, firstly, ballooning degeneration. Ballooning means the hepatocytes will swell up. It will increase in size. That is called ballooning. So consider this as a normal hepatocell is one cell of the hepatocyte. This is one cell. So it is roughly polygonal in shape. So normal hepatocyte is roughly polygonal or polyhedral in shape. It has granular eosinophilic cytoplasm and it has a central round nucleus. So cytoplasm, it is eosinophilic and granular. In ballooned hepatocytes, the cell will increase in size. The cell will increase in size. The nucleus, it will be pushed to one side, and the cytoplasm, it becomes pale. The cytoplasm becomes pale. So on the whole, the cell increases in size, cytoplasm becomes pale, nucleus will be intact, but it will be displaced. This is called a ballooned hepatocyte. This ballooning is due to defect in a normal pump present on a normal hepatocyte. This pump is called sodium-potassium pump. Sodium and potassium pump present on the surface of a normal hepatocyte. It This pump will undergo failure. Failure of this pump because of any infection, inflammation, or damage to the membrane. So in hepatitis, that is infection. So the membrane will undergo damage. Because of membrane damage, the sodium potassium pump failure occurs. So the sodium will get retained inside the cell. So no, a normal movement of sodium is from inside to outside. Sodium has to move from in to out. Sodium should move out. Sodium will be moving out and potassium will be moving in. This is a normal movement of ions across this ion transport channel. So, where because of this pump failure, sodium will stay inside, and along with sodium, water will also get retention. So sodium and water retention inside the cell will cause the cell to balloon up, to swell up. Hence, this ballooning degeneration is seen in viral hepatitis. So here the cell size will increase, that is swollen hepatocytes. Cytoplasm will be pale and finely granular, and the nucleus here will be intact. So it is suggestive of reversible injury. It is still a reversible injury. So in this histopathology, this is a ballooned up hepatocyte. It has increased in size. For example, this is a normal hepatocyte here with cell outlines and central round nucleus. Here the hepatocyte has increased in size. This hepatocyte, it has increased in size, nucleus displaced to one side, and the cytoplasm, it has become pale. So overall, it has swollen up. This is called a ballooned hepatocyte. It is a ballooned hepatocyte. Coming to other form of hepatocyte degeneration is a hydropic change. Hydropic change means the vacuolar cytoplasm. So in infection, because of this membrane damage, even the intracellular organelles like mitochondria, endosomes, endoplasmic reticulum, everything becomes defective. So glycogen, lipid metabolism will be impaired. It is mainly impaired because of impaired metabolism. Impaired metabolism will cause glycogen storage and lipid storage. It will get accumulated and get deposited in the form of vacuoles. So when you see this, this is one hepatocyte with a lipid droplet or glycogen droplet inside it. So the cytoplasm. Here, this is one hepatocyte. This is the cytoplasm. This is the cytoplasm like a signet ring, like to the periphery. This is the nucleus. So nucleus and the cytoplasm are pushed to the periphery because of this droplet. So this droplet of glycogen or lipid. So this vacuolar cytoplasm, appearance of this vacuolar cytoplasm, the hepatocytes, this is called a hydropic change. Hydropic change means vacuolar cytoplasm due to impaired metabolism of glycogen. It is impaired metabolism of glycogen and lipid. Coming to the other thing, Councilman bodies or the apoptotic bodies, also called acidophilic bodies. So, in our previous video, we have studied the pathogenesis wherein the cytotoxic T lymphocytes induce apoptosis of the infected hepatocytes. So, this infected hepatocytes they undergo apoptosis. Those bodies, that dead bodies, are called apoptotic bodies or Councilman bodies or acidophilic bodies. So as usual, like any other cell, apoptosis, because of apoptosis, the cell, it is a non-leakage process. The cell only, the cell membrane will be intact. The cell will become shrunken. It will become shrunken. So in this pathology, histopath image, you find this shrunken cell. This is the shrunken cells. These are the shrunken cells. When you concentrate, these are the shrunken cells. Cell size has decreased because all the contents they are brought together. It has brought condensed. The cytoplasm appears condensed. It will be more eosinophilic. When it is jam-packed, the cytoplasm will appear more eosinophilic than the adjacent normal hepatocytes. And the nucleus will also be condensed and pycnotic. Here there is a small nucleus, condensed pycnotic nucleus. This is an apoptotic bodies. These are the apoptotic bodies here. We also call the councilman bodies or the apoptotic bodies or the acidophilic bodies. So apoptotic or acidophilic bodies. The cell appears shrunken, cytoplasm will be condensed, nucleus is pycnotic, and it is due to cytotoxic T lymphocyte mediated apoptosis. Also, these apoptotic bodies they have a scattered spread. They are not inline or in groups. They are like scattered, spread throughout the liver parenchyma. That is called spotty distribution. Spots like a spot, scattered distribution throughout the lobules. This is about the morphological changes brought about by hepatocyte degeneration. And because of this direct cytopathic effect, in our previous video, we have studied how the natural killer cells will directly attack the infected hepatocytes. That is called direct attack, is called direct cytopathic effect, which is more predominant in hepatitis A and hepatitis E viruses. This direct cytopathic effect will cause direct killing or direct degeneration of the infected hepatocyte and the cytotoxic T lymphocyte mediated killing, both of which result in like a disruption of the hepatocyte. All these contents will leak out. Normal hepatocyte the cytoplasm contains certain enzymes, liver enzymes called alanine transaminase and aspartate transaminase. Whenever because of this disruption, the cell contents will leak out. They leak out and show up in the circulation. Therefore, in the blood follow-up, this enzyme levels, liver enzyme levels will be raised. That is, increase in AST and ALT. These enzymes will be raised because of this killing by the immune response. And also the spotty necrosis. We have discussed spotty necrosis in a previous video. Again, we'll be discussing now. Spotty means again scattered, single hepatocyte, scattered necrosis here and there. That is indicative of only mild to moderate hepatitis, not a full-blown hepatitis. Spotty means it is limited to mild or moderate hepatitis. So this is about the hepatocyte degeneration which occurs in these three forms. That is, this is a ballooned hepatocyte. This is a hydropic change, that is vacuolar cytoplasm because of impaired metabolism. Ballooned degeneration or the ballooning of hepatocytes is because of sodium potassium pump failure Whereas this vacuolar cytoplasm is because of impaired metabolism of lipids and glycogen. These are the apoptotic bodies. Apoptotic bodies or the Councilman bodies. It is due to apoptosis induced by the cytotoxic T lymphocytes. This is about the hepatocyte degeneration. Nextly, when we see the lobular changes in hepatitis, we come here to spotty necrosis. Spotty means single hepatocyte undergoing necrosis. So, it is characteristic of acute viral hepatitis and that too mild hepatitis. So, for example, you consider this hepatic lobule. This is one hepatic lobule. There are hepatocytes present in the form of hepatic plates. Hepatic plates. This is the central vein. So a single hepatocyte necrosis here and there. This is called a spotty necrosis. Spotty means a single scattered hepatocyte undergoing necrosis. That is a spotty necrosis, which is indicative of mild hepatitis. So it is usually self-limited. It is self-limited. Focal necrosis means Focal means a cluster of 2 to 3 cells. For example, adjacent 2 3 cells. This one cell, this is one cell or 3 cells. This is called a focal necrosis. So focal necrosis is 2 to 3 cell death at a time. And confluent means little larger than the focal necrosis. It will be more than three. So a group, a set, or a group or cluster of hepatocytes that undergo necrosis together. For example, here we take this set of more than three. So this large cluster of hepatocytes undergoing necrosis is called this confluent necrosis. These are large clusters. This will indicate severe immune-mediated destruction, especially seen with hepatitis B and hepatitis D infections. Now, coming to the bridging necrosis, bridging is larger than the confluent. So, bridging necrosis will involve a large group of hepatocytes between vital structures. Like, again, I'll draw this. This is one hepatocyte lobule. This is the lobule. This is the central vein. This is a portal tract. Consider a portal triad here with hepatic artery, portal vein, bile duct, and a lymphatic channel. So, again, I'm drawing the same. So, a set of hepatocytes between the central vein and this portal triad. So, between these, which when these set of hepatocytes undergo necrosis, it is called a bridging necrosis. Bridge means it is bridging between two vital structures like a portal tract and a central vein, or it can be between two adjacent central veins. It can be between the two adjacent central veins. A set of hepatocytes between two adjacent central veins of the adjacent lobules. So these are the two. This is first lobule. This is the second lobule. A set of hepatocytes connecting this central vein to this central vein between the two adjacent central veins of the adjacent hepatic lobules. That is called a central necrosis. Central bridging necrosis, or between the two portal tract, between these two portal tract, that is called a portal bridging necrosis. Bridging means it is connecting two vital structures, therefore it is called a bridging necrosis, which is one of the forms of lobular changes that we encounter in viral hepatitis. So even bridging necrosis, since it is larger than the confluent, that is larger than the large clusters of necrosis, it is seen in severe hepatitis, and there's an increased risk of fibrosis as it involves like large group of hepatocytes are undergoing degeneration at a time. So it involves fibrosis. It will incite more inflammation, more TGF beta production by the ito cells. So more fibrosis. It is like more associated with a chronic kind of course. Therefore, there's a risk of fibrosis on recurrence. When again it can recur, when if at all it occurs for a second time, this bridging necrosis, it will have highest probability of going into fibrosis. And this confluent and the bridging kind of necrosis, they are associated with severe hepatitis, and also they have a risk of fulminant hepatitis. Fulminant means within a short period, within a short duration, it has a rapid or severe outburst of hepatitis. It will like rapidly progress to failure because a large number of hepatocytes are undergoing this necrosis. It will rapidly go into failure. Therefore, this confluent and the bridging necrosis are associated with increased risk of fulminant hepatitis. So we are clear with these concepts, and let us see this histopath image. So this is one portal tract and this is central vein. So there are a set of hepatocytes running from here to here. This is a classical bridging necrosis. Necrosis you identify in this way. These are the normal hepatocytes. The cell outlines are clear with a central round nucleus. These are the hepatocytes. And the cytoplasm, few of the cytoplasm, they are clear because of glycogen. These are intact hepatocytes are present. We can see the intact hepatocytes. But when you consider this area here, you cannot visualize any specific cell outline. Only the nuclei are visible. The nuclei, like dots, they are visible. The cytoplasm is also there, but definite cell outline is not present. These are the necrosed cells. So it is almost running between this portal tract to this venule, to this central vein from here. So it is a form of bridging necrosis. Bridging necrosis means it bridges or it connects to two vital structures like portal vein and central vein. This is about the lobular changes. Thirdly, when we come to a portal tract and interface changes, portal tract means there can be inflammation around this portal tract that will be obscuring the portal tract. It is usually mild to moderate lymphoplasmacytic infiltrate. So, this is the portal tract area. It is completely obscured by inflammatory cells. Inflammatory cells, largely, they are lymphocytes. The round dot, exact dots are the lymphocytes. Plasma cells are this with eccentric nucleus. So lymphocytes will be like this. It is usually round with a complete round nucleus, whereas the plasma cells they are little oval shaped with eccentric nucleus. So this is a lymphocyte. This is a plasma cell. So lymphoplasmacytic infiltrate at the portal tract. This is one lobule. This is the portal tract. Completely the portal tract containing hepatic artery, portal vein, bile duct, they are completely obscured because of this inflammatory cells. So mild to moderate lymphoplasmacytic infiltrate common in this hepatitis, and plasma cells they are specially characteristic of hepatitis B because hepatitis B it expresses certain antigens like hepatitis B surface antigen or the envelope antigen. So these antigens, they invoke antibody production. They invoke an antibody production. Antibodies are formed from plasma cells. Therefore, plasma cells will get recruited towards the site of this in antigen presence. So these plasma cells obviously they are present in the blood circulation. Blood circulation means portal tract that contain portal vein, hepatic artery. So the place where the hepatic artery, portal vein are present are the portal tract. Therefore, the portal tract will be surrounded by these plasma cells, especially in hepatitis B, because hepatitis B will express the surface and envelope antigens. Yes. And coming to the interface hepatitis, the interface hepatitis is also mild in acute hepatitis, acute viral hepatitis. The interface hepatitis is mild. It is marked and severe in chronic hepatitis and autoimmune hepatitis. So, this is marked in chronic and autoimmune hepatitis. Interface hepatitis means you consider this as hepatic lobule. Here is a central vein with a tract, portal triad. So the space the lymphocytes are present, this inflammatory infiltrates surrounding in between this hepatocytes of this lobule. These are the hepatocyte lobule. Lobules contain the hepatocytes, and this is the portal tract. So inflammatory infiltrate are present in between them, between the portal tract and the lobule. Also, it may get obscured over this portal tract. It may be infiltrating into the hepatocytes of the lobule. So mainly it is present at the junction between this lobule and the portal tract. It can be so severe that it may be infiltrating into the portal tract and into the hepatocytes of the lobule. This is called interface hepatitis. interface hepatitis is mild. In acute hepatitis, it is more marked, it is more characteristic of autoimmune hepatitis and chronic hepatitis. Coming to the next part, Kupffer cell changes. Kupffer cells are the macrophages of the liver. Here there will be Kupffer cell hyperplasia. Kupffer cell hyperplasia means Kupffer cells is increase in number. This increase in number is called hyperplasia, which is a normal immune response. Since in viral hepatitis there is infection, means it will invoke an immune response. Immune response means macrophages. Macrophages are the immune cells. The macrophages of the liver are the Kupffer cells. Therefore, Kupffer cells will increase in number. They will increase in number, they become very active, and they eat up the dead cells. They eat up the dead cells which have undergone apoptosis or the necrosis, and they eat away the debris also. Because they're so hungry and they eat away, they increase in size. They eat, they increase, they bulge out, they increase in size. So they enlarge. And the cytoplasm, because they eat away all these contents, the cytoplasm will appear granular. Granular because they contain this phagocytosed material. So this is about the Kupffer cell changes we see in acute viral hepatitis. So this is one histopathology image wherein we see this Kupffer cells. Kupffer cells are the macrophages that line the sinusoids. So these are the hepatic plates. These are the strands of hepatocytes. The space between the hepatic plates, these spaces, empty spaces, are the sinusoids that contain the blood. The sinusoids are lined by endothelial cells, also these macrophages. So the space, the vascular sinusoidal space, they are lined by macrophages, that are the Kupffer cells. So whatever toxins, drugs that enter the circulation will come into the sinusoids. It will be taken up by the Kupffer cells. Toxins like even the virus in an attempt to kill the virus, or any drugs injected, or toxins present in the blood taken up by the Kupffer cells. Here in this liver biopsy, the patient was injected with a carbon infusion. So these Kupffer cells, they have like a phagocyte of the carbon particles. Therefore, they appear black dots over these Kupffer cells are the carbon particles. This shows the phagocytic activity of the Kupffer cells or the macrophages. They have taken up this carbon particles which are black dots, which appear as black dots. The black dots around the Kupffer cells. These are the Kupffer cells or the macrophages of the liver. Nextly, there can be cholestatic change. Cholestatic change, it is especially seen in hepatitis B and C and some ANE cases, mostly with hepatitis B and C. So cholestatic means bile plugs can be seen in canaliculi. So this is one hepatic lobule. It contains hepatocytes. Between two hepatocytes, these are the biliary canaliculi. Whenever there is infection, as we have studied, there is ballooning of the hepatocytes. They swell up, they increase in size, they swell up. And also because of inflammation, infection means there will be inflammation, inflammatory cytokines. So because of inflammation and inflammatory exudate, they'll block this canaliculi. This canaliculi will be blocked. This is blocked. So the bile will be like stagnant in the canaliculi. In this channels, the bile will be stagnant. This is called bile canaliculi plugging. These are called the bile plugs in the canaliculi. In this stain, an HNV stain, or the special stain for bile is this Hall stain. Hall stain is the special stain for bile. Here we can see this yellow pigments. These are the yellow pigments in between these hepatocytes. These are these are the bile plugs. Bile plugs seen in the biliary canaliculi. So this is seen in cholestatic changes in hepatitis B and hepatitis C because there is a chronicity or there is excess inflammation. So channels get blocked. Therefore, bile plugs are formed. And lastly, there can be in fulminant or massive necrosis. There can be massive hepatocyte loss. Fulminant means sudden outburst, explosive. Massive necrosis also. Huge clusters of hepatocytes will be lost. That will result in collapse of the lobular architecture itself. So, when all the hepatocytes present within the lobule, they undergo necrosis. The entire lobule will collapse. Entire lobule collapses means the collapse there will be like loss of reticulin framework, everything will collapse. It will rapidly result in acute liver failure, and there will be coagulopathy. Why coagulopathy? Because hepatocytes synthesize clotting factors. When all the hepatocytes are damaged, clotting factors synthetic activity goes down. So clotting factors are not synthesized, that will result in coagulopathy. Also encephalopathy, because liver is the major detoxification center of ammonia. So ammonia is detoxified in the liver by this urea cycle. When liver is damaged to such an extent in massive necrosis, all the hepatocytes get damaged. Liver is unable to handle this ammonia for detoxification. The ammonia levels will rise in the blood. It will cross the blood-brain barrier. Ammonia will cross the blood-brain barrier, enter the CNS, that is responsible for this encephalopathy. So in fulminant or massive necrosis, we find this other side complications are coagulopathy and encephalopathy as a result of decreased synthetic activity and decreased, like, lost detoxifying function of the liver. Coming to the morphology in gross, we'll study the gross. Grossly, the liver will be homogeneously enlarged. Homogeneous means uniformly enlarged. No, there's no such thing like nodules. One side it is enlarged, one side normal. It is uniformly enlarged, that is homogeneously enlarged, and it will be congested because we have studied ballooning degeneration. Hepatocytes swell up. For that reason, there will be hepatomegaly. Grossly, they appear enlarged and congested because of inflammation. Inflammatory mediators will cause vascular congestion of the sinusoids. Therefore, they appear congested. And there will be, because of hepatomegaly, there will be stretching of the Glissen's capsule. Glissen's capsule is the outer covering or the outer fibrous covering of this liver. When the liver bulges, when the liver enlarges, it will bulge. It will create a tension. It will stretch the capsule covering it. So that is called stretching of the Glissen's capsule. Because of this stretching, the capsule appears shiny. It will appear tense and shiny. Shiny because of inflammatory mediators, there can be edema. Edema under the capsule. Due to edema under the capsule, it appears shiny. Here, see the surface, it appears shiny. This is the surface appearing shiny. So it is uniformly enlarged, appears like tense. The capsule will be stretched. It appears tense and the shiny because of edema underneath it. And it is usually soft because of cell swelling. It appears like pudding. It appears that soft, like a pudding. It appears soft. On cut section, it is reddish brown. On cut section, it is reddish brown because of vascular congestion. Inflammation will cause vascular congestion. The vascular sinusoids will be congested. Therefore, upon cutting it, it appears reddish brown. If at all there is cholestasis, it will appear greenish brown. In cholestasis, it is greenish brown. And it is friable, means when you attempt to cut it, the knife will easily go into it. And also when you try to handle it with your fingers, it appears as if it will easily fall off. The fragments will easily fall off. It appear That is called friable. It is due to focal necrosis. Focal necrosis means here and there. Two, three clusters of cell undergoing necrosis. So all throughout the liver parenchyma, there are focal areas of necrosis. Because of necrosis means dead cells which easily fall off when you apply pressure with your fingertips also. So when you try to handle the cut surfaces, the segments will easily try to fall off, slip off from your fingers. That is called friable because of focal necrosis. Again, coming to the microscopy, let's revise again. We see ballooning, we see Councilman bodies, that is the apoptosis. Ballooning means because of sodium potassium pump failure. Apoptosis, Councilman bodies. Spotty necrosis, single scattered hepatocyte necrosis, which is indicative of mild hepatitis. Cover cell hyperplasia, that is immune response. Inflammatory cell infiltrate, obviously infection will invoke the inflammatory cell recruitment and cause infiltrate. And in severe cases, we see confluent, bridging, and the massive necrosis. This is about the morphology microscopy. Coming to the pathophysiological consequences. So, because of hepatocyte death, as we have discussed, either ways, because of apoptosis or necrosis, anyways, the cell contents will leak out. So, cell contains in the cytoplasm, it contains transaminases enzymes. So, there will be increase in alanine transaminase and aspartate transaminase. And especially in viral hepatitis, The ALT levels will be more raised than the aspartate transaminase. So, in alcoholic hepatitis, AST will be raised. AST mainly present inside mitochondria as well. When alcohol mitochondria injury occurs, therefore AST will be more. That we'll discuss in detail in alcoholic hepatitis. For now, in viral hepatitis, ALT will dominate, alanine transaminase. Alanine transaminase will be more dominating than the aspartate, though both transaminases will increase, that we can remember. And there will be disruption of bilirubin metabolism. So hepatocytes will, under a few of the hepatocytes, they retain their function, few others will undergo necrosis. So there will be rise in both conjugated and unconjugated. So whatever bilirubin that hepatocytic globule they receive it, the necrosis surviving hepatocyte, they will conjugate bilirubin. They'll receive the bilirubin, indirect bilirubin. They will conjugate it and form a direct bilirubin. So there will be rise in direct bilirubin because they are unable to excrete into the bile. Because of inflammation, there will be bile plugging. There will be like obstacle at the site of biliary canaliculi. They cannot excrete into the bile properly. So it will backflow into the blood. Therefore, there will be rise in direct bilirubin, and also few of the hepatocytes they undergo necrosis. So there are not enough number of hepatocytes to conjugate. Therefore, both indirect bilirubin also will rise. There is a pattern of mixed hyperbilirubinemia, because of which there is jaundice. So bilirubin presence in blood cause jaundice. That is, it will lead to pruritus, yellowish discoloration of the skin, mucous membrane, sclera, and dark urine because blood will have increased bilirubin which is excreted via kidneys. So bilirubin will come out in the urine as dark color, tea colored urine, and there will be pale stools because bilirubin is not excreted into the bile. So the intestine does not receive this bilirubin in quantities enough to produce stercobilin. Absence of stercobilinogen will cause pale stools or the clay colored stools. This is the reason behind the pale stools, dark urine, and jaundice. Because of disruption of bilirubin metabolism, hepatocyte dysfunction causes all this rupture, all this chaos. And there is Kupffer cell activation and cytokines. So macrophages they get activated and release cytokines like interleukin 1, tumor necrosis factor alpha. These are responsible for the systemic symptoms like fever, malaise, anorexia, which are characteristic of this hepatitis because of cytokines. Anorexia, and it is especially towards, and the patient feels aversion for food, aversion for especially fatty food, which is classical of viral hepatitis. And there can be fulminant hepatitis. That means fulminant means sudden explosive outburst. So because of massive necrosis, rapid failure occurs. That means there will be collapse of all the reticular network of the lobules. Lobular architecture will be lost. So collapse of reticular network. It will rapidly lead to acute liver failure, coagulopathy because synthetic function goes down, clotting factors not synthesized, and encephalopathy because of ammonia. Ammonia is not detoxified, it crosses the blood-brain barrier, causes encephalopathy. Coagulopathy because of clotting factors not being synthesized. So this is about the pathophysiological consequences. Coming to the resolution. So after this hepatitis, body tries its maximum to eliminate the infection. So whether it resolves or it will progress further, causing chronic disease will depend on the immune status of the host. So in immune response, it depends on the immune response. If the immune response is strong, it will clear the infection and the hepatocytes will regenerate. Once the problem solved, the hepatocytes will grow. It will try to regenerate, will regarden itself. So there will be complete recovery. And especially hepatitis A and E, since it has short incubation period of we have discussed in the first video, so it is 2 to 6 weeks. The first column, fifth column, A and E, 2 to 6 weeks the shortest incubation period, and they spread by fecal-oral transmission. Therefore, they are self-limited and there will be no chronicity. Therefore, complete recovery occurs in hepatitis A and E. Coming to the second column B, The hepatitis B depends on the host itself. If he has a strong cytotoxic T lymphocyte clearance, when his immune defense mechanism is strong, he will be able to clear the infection. So there will be clearance. If it is weak immune response, then it can progress to chronic course, or he can become a carrier. So chronicity carrier stage is because of weak immune response. Coming to the hepatitis C is mostly associated with weak immune response. It cannot give a strong response. Therefore, it is associated with high chronicity. High chronicity, in almost 80% of the patients will land up in chronicity with hepatitis C. Coming to hepatitis D is the dependent virus. D will depend on B, second and fourth column. So D will depend on the B. It will coexist with B. D is a dependent virus. Depending means it will always coexist with hepatitis B. So presence of two hepatitis B and D, double dhamaka, will cause more infection. So there is a high risk of fulminant or the chronic state. It will rapidly progress to failure, or it will go into chronic state. This is about the resolution or the chronicity part. It depends on entirely on the immune clearance mechanisms. Coming to the clinical features, so clinical features we can divide into these four stages. Incubation period. Incubation period is this asymptomatic period during which the virus replicates inside the host cells before any clinical manifestations or clinical symptoms pop up. It's a silent phase. It is a silent killing phase. So incubation period depends from virus to virus. Again, let us revise the etiology table that we have discussed in the first part. So first column, fifth column, A and E have short incubation period. So tell me, short incubation period is between 2 to 6 weeks. 2 to 6 is A and E, the outermost two tables. A first column and a fifth column. Come inside B and D. So the incubation period is between, you have to continue from A. So after 6 comes 7, 7 to 20. So B and D will have 7 to 20 weeks incubation. C will have the centermost column, will have, you have to take the two extremes of these two. So short extreme is 2 weeks. The longer extreme is 20, if we said in B. So 2 to 20. It is between 2 to 20 in hepatitis C. So summarize again. Hepatitis A, hepatitis E will have 2 to 6 weeks. Hepatitis B, D will have 7 to 20. C will have 2 to 20 weeks. So incubation period is a silent period. It is asymptomatic, during which the virus will only replicate. It will viral replication before any immune response is mounted. This is about the incubation period or the asymptomatic period, which this period depends. The duration will depend on the from virus to virus. It will change. Coming to this prodromal phase, prodromal means like before jaundice develops, the generalized systemic symptoms like fever, malaise, anorexia, as we have discussed, is because of interleukin 1 TNF alpha. It is secreted by the macrophages. So these are responsible for the generalized symptoms like fever, anorexia, malaise, weakness, fatigability, easy fatigability. All these are because of interleukin 1 TNF alpha. This is the pre-icteric. Icteric means jaundice, pre-jaundice period or prodromal phase. Coming to this icteric phase means icterus means jaundice. So jaundice phase. In icteric phase, there will be jaundice, dark urine, pale stools. Jaundice because of rising bilirubin in the blood. Hepatocytes will be, some will conjugate, some will not. Because of necrosis, they are not able to conjugate. Both levels rise in blood because they are unable to excrete into the bile and cannot excrete into the intestine finally. So will be rise of bilirubin in the blood that will cause jaundice, pruritus. And because blood levels rise, they are excreted via kidneys into urine. So tea colored or the dark color urine. Because they are not able to excrete in bile, bile ultimately goes into intestine. Intestine not able to receive good enough quantities of bile which contain bilirubin. No stercobilinogen. No stercobilinogen means pale stools, clay colored stools. So the jaundice, dark urine, pale stools are because of this bilirubin metabolism defect. Hepatocyte necrosis will cause this bilirubin metabolism failure. Sorry. It will cause this bilirubin metabolism failure, And generally the bilirubin levels will be more than 2.5 mg per deciliter in acute viral hepatitis. And there will be in icteric phase, there will be hepatomegaly because of initial ballooning degeneration. Hepatocytes swell. Because of hepatomegaly, there will be tenderness. On palpation, there will be like right upper quadrant pain, inspiratory arrest on this right upper quadrant pain is because of this hepatomegaly. There can be splenomegaly, but it is more common in chronic case of hepatitis B and C because there will be lots and lots of inflammation. So the because of vascular congestion, the portal hypertension will occur. Portal hypertension means backflow of blood into the spleen. Portal vein carries blood from spleen, from pancreas, from intestine. From all these three places, the portal vein carries blood to liver. In the liver, there is inflammation. Liver congestion will happen. Because of congestion, this blood can't move inside the liver. It will stay stagnant. It will backflow. Because of backflow, spleen receives more blood. It will backflow. So splenomegaly is seen because of heavy inflammation in hepatitis B and hepatitis C. And there's pruritus because of increased bilirubin in cholestasis. We see in cholestatic means there's obstruction to the bile outflow. Bile cannot be excreted. Therefore, the bilirubin will be pumped back into the blood. So, increased bilirubin levels in the blood will cause pruritus. Most commonly seen in cholestatic hepatitis A, hepatitis E. Hepatitis A and E most commonly associated with this pruritus, that's itching. Coming to the last phase, that is the convalescent phase, that is the recovery phase. It occurs few weeks to few months, and the resolution of there will be resolution of the symptoms and the lab values. And as we have discussed before, hepatitis A and E, because it has short incubation period and fecal-oral transmission, shortest incubation period means it is self-limited. It has a complete recovery. So it has a complete recovery, A and E, whereas B, C, D, it has a progression to chronic hepatitis and they become carriers. So in convalescent phase, complete recovery occurs with A and E, whereas chronicity carrier state is more commonly associated with hepatitis B, C, D. This is about the clinical features of acute viral hepatitis. Coming to the lab investigations, the routine blood test, the CBC, the complete blood count, the WBC count will be normal, which is suggestive of viral hepatitis. If it was raised or deranged WBC count, it would be suggestive of bacterial. In viral hepatitis, the WBCs are normal and there will be atypical lymphocytes. Atypical means bad looking lymphocytes because of reaction to viral infection. The lymphocytes will show some reactive changes in the morphology. Either the cell membrane become irregular, nucleus become large. So some atypia means bad looking lymphocytes suggestive of viral hepatitis. And platelet counts drop because in hepatitis B and C there will be severe marrow suppression. B and C associated with severe marrow suppression. Marrow suppression means WBCs that precursors not formed. Therefore, the WBC, the platelets count will go down. Because precursors are not formed, the platelets go down because of marrow suppression. And also the cytokines. In infection, there are inflammatory cytokines. Interleukin 1, TNF alpha, interferon gamma, all these inflammatory cytokines will inhibit the platelet function. Whatever the platelets, low platelets are present, they are also like low function, defective function because of this inflammatory cytokines. So complete blood count will show because it is viral, WBC will be normal, atypical lymphocytes present, and platelets, the count will go down. Platelet count will be low, especially with hepatitis B, hepatitis C because of marrow suppression. And also the inflammatory cytokines will reduce or inhibit the platelet function. Whatever platelets are present, they'll inhibit their function. Coming to the liver function test, as we have discussed a number of times, the serum transaminases rise because hepatocytes undergo degeneration, the cell contents leak out. The transaminases, alanine transaminase, aspartate transaminase will rise. So the ALT will be more than the AST. Alanine will dominate over the aspartate, which is suggestive of viral hepatitis. And the levels will be usually, both the transaminases, the levels will be usually more than 500 international units per liter, which is suggestive of acute viral hepatitis. So transaminases will rise among this liver function test. Other thing is bilirubin. Conjugated bilirubin will rise. Both direct, indirect will rise, but there's predominance of conjugated bilirubin will rise due to impaired secretion. There will be impaired secretion from the hepatocytes. So this is hepatic lobule. There are hepatocytes, bile canaliculi in between them, and there is an this port MRP2 port, MRP2 port, which via which the bilirubin, conjugated bilirubin, will pass into the biliary canaliculi. So, because of this heavy inflammation, this canaliculi may get occluded, because of which bile, that conjugated bilirubin, are unable to pour themselves into this bile. So, conjugated bilirubin will backflow into the blood. It will rise in the blood because of this impaired secretion from hepatocytes that will result in jaundice and dark urine because they are excreted via kidneys. So, urine becomes tea colored. And coming to this alkaline phosphatase, it is and gamma glutamyl transferase. These are useful to rule out the obstructive causes of hepatitis like gallstones also, because the ALP they are secreted by this bile canalicular epithelium. So between the hepatocytes are this biliary canaliculi. These channels are present. They are lined by epithelium. This biliary canalicular epithelium release this alkaline phosphatase. Therefore, any obstruction in this biliary outflow, either because of gallstones, tumors, any reason, the ALP will rise. In acute viral also, because of inflammation is plugging, bile plugging, it can be mildly elevated, not heavily elevated. Can be mildly elevated or most of the times it will be normal. But this ALP, it is not specific for this hepatobiliary origin. It is also present in bone pathology, kidney pathology, or placental pathology. So therefore, to confirm whether it is of hepatobiliary origin, we need to do another enzyme called gamma glutamyl transferase, which is very specific of liver. If both ALP and gamma glutamyl transferase are raised both, then it confirms this hepatobiliary origin. So if these two are raised, it confirms that there is some the obstruction to the bile outflow because of gallstone, that is post-hepatic hepatitis. Here we do it here in this viral hepatitis because it is like hepatic cause. These both they stay normal or will mildly elevated, but mostly it is normal. So it is done to rule out obstructive causes. In viral hepatitis, it is normal, mostly normal, or it can be mildly raised because of only this bile plugging. That's it. And coming to this albumin, albumin is normal in acute hepatitis because the liver function is the hepatocytes they do not when they are do not undergo massive necrosis, still some synthetic function is retained. Therefore, in acute early phases, the the protein levels, the albumin will remain normal, and albumin level will go down in chronic or fulminant or like massive necrosis stages. So it will decrease in this chronic phase, increase in chronic or the fulminant rapid failure phase. The synthetic function goes down, the protein goes down, the albumin also goes down. And coming to this PT-INR, so even the clotting factors in early stages, they are normal, but as they progress to chronicity or there is hepatocyte heavy damage or it is going to fulminant failure, then clotting factor synthesis doesn't happen. It will lead to prolonged PT and a prothrombin time and INR will rise. So it is suggestive of severe hepatocellular damage. Prolonged PT means it is suggestive of severe hepatocellular damage. So this is about the lab investigations. Coming to the urine and the stool test also, urine bilirubin will be raised. Urine bilirubin will be raised because the direct bilirubin will be raised in the blood because it cannot be excreted into the bile. It is raised in the blood. Direct bilirubin is water soluble. So from the blood, it will go into kidney via kidney excreted into this urine. It appears in the urine, and the urine urobilinogen will be raised because whatever a little conjugation happens, even though it is able to excrete into the intestine, the little, For example, this is hepatocyte globule. These are the hepatocytes. Whatever the bile, direct bilirubin formed, they're excreted into the bile and they go into this intestine, little, and they form urobilinogen here. So all this urobilinogen via this portal circulation again come back to liver. They're taken up by these hepatocytes again, but they're not able to excrete it again because the excretory system of hepatocytes for this urobilinogen is different. Okay, the direct bilirubin they are able to excrete via this MRP2 port. MRP2 port is still present. This is other excretory function. For this urobilinogen, the excretory function is different. It is blocked in this hepatitis. Therefore, it is unable to re-excrete into the bile. It will go into the blood. This urobilinogen will go into blood. Again, from blood it will go to kidneys. From kidneys it will appear in urine. Therefore, urine urobilinogen levels will rise. Urine urobilinogen levels will rise because hepatocytes fail to re-excrete it. One time it will excrete, conjugated bilirubin will be excreted. Urobilinogen is formed. Again it will take up but unable to excrete, re-excrete into the bile because it is impaired. The transport or this excretory transport mechanisms are impaired, completely shut down in viral hepatitis, and it is used to rule out obstructive cause. In obstructive causes, this it is very low. In obstructive, the bile itself it is completely not excreted into intestine. There is completely no formation of urobilinogen. Complete no formation of urobilinogen. There is nothing formed in the blood. So urine does not contain this urobilinogen in obstructive causes. Coming to this pale stool, we have discussed it is because of low bile pigments reaching the intestine. Stercobilinogen is not formed. Hardly any bile is coming into the intestine, which will form urobilinogen, or it will reach up to the last part of this intestine and form stercobilinogen. So, lack of stercobilin will cause this pale stools. This is about the urine and the stool test. Urine bilirubin will be raised because there is increase in direct bilirubin. The direct bilirubin is water soluble. Water soluble, that means it will reach kidneys and get excreted into the urine. So urine bilirubin will be raised, and urine urobilinogen is also raised because some conjugated bilirubin little part which is excreted into intestine will come back to liver via portal circulation, and when it comes back it is again unable to re-excrete it back into the bile because it has a separate excretory mechanism which is failed. Therefore, this urobilinogen will go back, it will backflow into blood, reach kidney, come into the urine. Urine urobilinogen will rise because of this failure to re-excrete. Pale stools because the stercobilinogen is not formed, because of which the bile pigments decrease, reaching the intestine, pale stools, clay-colored stools. This is about the urine and the stool examination. Coming to the serology, the virus-specific serology. So hepatitis A will have this capsid protein. Hepatitis B, interestingly, they have surface antigens. These are the surface antigens here. These are the surface antigens. And there is an envelope antigen. Inside the surface, there are envelope antigens and there are core antigens. Hepatitis C, this RNA virus, which is antigenic. Hepatitis D has this hepatitis D antigens, and there is a nucleo-enveloped capsid for hepatitis E also. So, in acute cases of hepatitis A, we have this anti-HIV IgM antibody. So, this hepatitis A antigen does not appear in the blood. The hepatitis A virus is directly shed into stools, so it does not appear in blood. Whatever appears in blood is the antibody. In early phases, the early response given by this pentamer called IgM. So, IgM is the first one to appear in the blood. Let's discuss about the acute. For hepatitis B, so there is presence of hepatitis B surface antigen, E antigen. The core antigen is present into the core, to the core of the virus. Only inside it is present, so it does not appear in the blood. Only surface antigen, envelope antigen will appear in blood, and the counterpart for this core antigen is this antibody, which is IgM. In acute cases, in acute phase, the anti-HPC IgM antibody will appear in the blood. Coming to this hepatitis C RNA itself appears in the blood in acute cases. And coming to the D, so in D also, there is hepatitis B RNA virus RNA will appear and IgM antibody, anti-HDV IgM antibody will appear in the blood. And for HEV, this HEV RNA appears, and the antibody, IgM antibody, anti-HEV antibodies will appear. So, altogether, in acute cases, in acute hepatitis, IgM antibody will predominate, not IgG. M means acute. So, for hepatitis A, there's no antigen. So, directly antibody, anti-HAV, IgM antibody. For hepatitis B, there is surface antigen, envelope antigen, and core antigen is absent, core antibody will be present. Antibody, which antibody? Because it is acute, it will be IgM. For HCV RNA. HDV, there is a HDV RNA and immunoglobulin, IgM immunoglobulin. For E also there is RNA and there is IgM antibody. So this is about the acute hepatitis serology. Coming to the chronic, we'll see the chronic also. In chronic, it will be the counterpart immunoglobulin, that is G. Chronic means immunoglobulin G. So in hepatitis A, we find anti-HAV. We'll have this anti-HAV IgG antibody. For uh, for this hepatitis B, we'll have the same in the highly infective cases. We'll have hepatitis B surface antigen, hepatitis B envelope antigen, and anti-hepatitis B core antibodies present, but it is immunoglobulin G type. It is G. So in chronic hepatitis B, we have surface antigen, we have envelope antigen, and core antibody, which is IgG. This is about the chronic hepatitis B. And for this hepatitis C, we have this counterpart immunoglobulin G, anti-HCV-G. For D, again anti-HDV IgG. For E, again anti-HCV IgG. So all this immunoglobulin counterpart G is similar. This G in everything G is there. This is also G. For this chronic hepatitis B, we have surface antigen, envelope antigen, and core immunoglobulin, which is IgG. So this is about the serology viral markers. Coming to the molecular test, PCR, reverse transcript test PCR can be done. It will detect the viral genome. Either it is for hepatitis B, it will detect DNA. For all rest all viruses, it will detect the viral RNA. It will detect viral genome. It is useful in early infection. Before this antigens or antibodies appear, viral genome will appear. So it is useful in early infection and it will quantify the viral load as well. Others, imaging can be done for hepatomegaly like ultrasound, CT, and liver biopsy rarely done for acute hepatitis, but if at all it happens, it is rarely done in acute. If it is done, it can be done for chronic or uncertain diagnosis, you can do liver biopsy. Coming to the complications of acute hepatitis, firstly, fulminant hepatitis. Fulminant means rapid failure or explosive outburst. It is seen more commonly with, like as we have discussed, hepatitis B virus and hepatitis E. It is most common in pregnancy. So whenever this fulminant hepatitis, wherein massive necrosis occurs, the synthetic function goes down. So there will be coagulopathy. That is because of clotting factors go down, and encephalopathy because of ammonia detoxification does not occur, and it can progress to chronic hepatitis. Acute may progress to chronic hepatitis because of failure of complete immune clearance. If the host immune response is not strong enough, the infection will persist for a longer duration that will progress to chronicity. So chronic hepatitis seen because of incomplete removal, and mostly hepatitis C will have this weak immune response. So 80% of the infection will land up, 80% of the patients will land up as these carriers. So they have weak immune control. Hepatitis B and D also, 5 to 10% adults show this chronicity and 90% of the neonates. And it depends on the immune response. If the adults have strong immune response, well and good, it will be cleared. If not, you'll land up as chronic carrier state. And neonates, because of immature immune clearance mechanism, 90% of neonates will become chronic carriers. And hepatitis A and E, because of short incubation period and it is self-limited, there's complete removal of the virus, so there's no chronicity, it is self-limited. And carrier state most commonly seen with hepatitis B and C. Hepatitis B and C because they show more of this carrier state. And rare complication is after the infection subsides, there can be autoimmune trigger. So autoimmune hepatitis can occur post after this infection. These are the complications, and there can be certain extra hepatic manifestations. Hepatitis means we think only about the liver manifestations. There can be extra hepatic manifestations like the polyarteritis nodosa, membranous glomerulonephritis. So, polyarteritis nodosa, membranous glomerulonephritis, seen more commonly as a complication of hepatitis B, and mixed cryoglobulinemia, lichen planus, membranoproliferative glomerulonephritis. All these three, mixed cryoglobulinemia, lichen planus, membranoproliferative glomerulonephritis, all these are the complications, extra hepatic complications of hepatitis C. So this is all about the acute viral hepatitis. We have completed the discussion about acute viral hepatitis. This is the part 2 video. So if you like this video, please like, share with your friends and subscribe to our channel. Thank you everyone.